We have a little panel discussion for questions and answer. Any questions from the floor? Yes.
Dr. Misa from Tokyo, Japan. Thank you very much for nice presentations from the authorities. Professor Wakabayashi mentioned that the dissected surface of the liver sometimes become irregular. He used the term zigzag. For the solution, what do you think about the solution? In my opinion, if the dissecting device like a CUSA or something like that, with bendable or articulating devices we have, it's going to be fine. What is your solution at present time?
Professor Wakabayashi?
Yes.
Then your question is the division of the parenchyma?
Oh, yes. Sometimes become, because of the limitation of the tools, movement of the tools, it becomes so irregular and zigzag.
Then the question, if I'm understanding correctly, is there are some places during your dissection that you can do it very straightforward, but then you show an area that was very difficult, and what are your suggestions of what to do then?
Because craniocaudal plane is easy, but if it's a kind of vertical?
Transverse.
Transverse is very difficult. So you have to think about the place, trocar placement position.
Yeah, but
maybe you can simulate by DICOM data.
But sometimes you have to dissect transverse. So in that case, do you have any technique or a solution? In my opinion, if we have devices with bendable or articulating.
Yeah, if you have some articulated device like a Da Vinci.
Well, we don't have.
Yeah, better. And, or you can mobilize the lever and move the ground.
Move the ground technique. Okay, thank you very much.
Any other suggestion from the other panelists about what to do when you're doing the transection on a transverse fashion, besides trying to move the liver once it's completely mobilized? Dr. Han?
Yes, as Dr. Wakabayashi explained, as I think the transverse incision is transverse transection is difficult. So I try to align the transection line with the instrument. So the way is that one is traction. So as I've shown in my presentation, we can place the straight suture, then track the upward or downward. So we try to make alignment, and also we can have a trocar in the upper part. So by using the trocar placement and using the straight suture, we try to align the instrument line and transection line parallel.
Okay, and then the answer is to try to align the transection line with the instrument, and the suggestion of the trocar came also from Gaillet, that sometimes puts a trocar between the ribs, even through the chest. David, any other suggestions?
No, the non-cirrhotic normal liver, it's much easier because the liver's floppy and you can bend it once you have full mobilization. But as we saw in the videos, the cirrhotic liver, that's impossible or very difficult. So again, it's all about trocar placement. And I agree that's one major advantage of my partner uses the Da Vinci, because the robotic instruments can reticulate a full 90 degrees high up under the rib cage, and we have difficulty doing that with the rigid, pure laparoscopic approach. So I think that is one strength, advantage of the robot for those using it.
Please, anybody, if they have any questions, don't hesitate to come to the microphone. We have 3 superior technicians in terms of liver resection with a tremendous experience. Then my question is going to be, when today, if ever, you decide I'm not doing it laparoscopic or hand-assisted, when do you decide I'm still doing this completely open? Professor Wakabayashi?
As I showed you in my last slide, our indication for open is a big tumor. It's very hard to mobilize. So maybe we can give a thoracoabdominal incision, such a big tumor, like a 20 centimeter, or embedded to diaphragm, embedded to other organs. And also, portal vein thrombus and hepatic vein thrombus, probably it's better to use your hand, not like forceps. So
Okay.
I think open is just in our series, large tumor and severe adhesion and vein invasion.
Professor Han?
I'm sorry, I don't have any much experience of laparoscopic assist operation or hand assist. I usually perform pure laparoscopic procedure. But if I do laparoscopic assist, I think that maybe Professor Wakabe shows that the liver transplantation may be the one indication. Another maybe if there is a major big bleeding, there is no time. But if we can compress it well, and we cannot control it with laparoscopy, and we have to control with gauze, compressed, then we may try incision, then repair it. It's one indication.
But is there any case today that you say, no, I'm not going to try laparoscopically before the surgery, or do you tackle all your livers laparoscopically? Is there any indication for which you would say, I'm going to do this case open?
As Dr. Wakabe is big surgery, I never think about the laparoscopy. So if my large incision, I do open surgery, not laparoscopic assist. Yeah.
David?
Besides the situations already mentioned, we're still very conservative. So hilar cholangiocarcinoma, open. The common case of multifocal bilobar colorectal metastasis that maybe have been downstage a little with neoadjuvant chemo, where you're doing a hemihepatectomy and a few wedges on the other side. That case still, so 6-8 mets, still open. So those two, hilar cholangio, multifocal bilobar colon mets.
But for everybody, why don't you explain why hilar cholangio wouldn't be good? Is it the anastomosis? Is it that you don't feel comfortable with the oncologic? What is what makes you do it open?
All of the above, because those are difficult cases even open.
Yes, cholangiocarcinoma, there are two the more difficult thing. One is that cholangiocarcinoma, it's not I'm not talking about Klaskin or bile duct carcinoma, intrahepatic carcinoma. There's some satellite nodules. So it is one problem, and another problem is that we have to do lymph node dissection. So when we perform laparoscopic resection for cholangiocarcinoma, there we have to have in mind that satellite metastasis or lymph node dissection. So this is the obliteration. But I think that we are progressing. So there may be some good report on intrahepatic cholangiocarcinoma in the future.
Okay, we have a question from the audience.
Yeah, thank you for some wonderful presentations. To pick up on the point that Dr. Geller was alluding to, a lot of what we see in our practice today is the patient with multiple colorectal metastases. A lot of them have received neoadjuvant therapy, some of them with oxaliplatin, and they come in with a blue liver. And so for those patients, would you even if it's a resectable disease and maybe not more than 1 or 2 lesions, any experience with chemotherapy liver laparoscopically versus open, does it make a difference?
Again, can you repeat the question? Any experience with after chemotherapy to do a laparoscopic versus open?
Correct.
And the question is, if a patient has received neoadjuvant therapy, does that make you decide one over the other, or you don't take that in account? David?
Well, regardless of the approach, we all know the chemotherapy damages the liver, and they can get steatohepatitis and sinusoidal dilation. So the message we deliver to the medical oncologist is, if either up front they're going to be a surgical candidate, or if they're downstage, we like to get them to the operating room after 2 or 3 months and not 6 months. And then the issue is, it's more of a technical issue. In terms of deciding laparoscopic versus open approach is based upon the number and location and size and extent of the tumors, not so much the background liver. But I think it's the same issues. If it's a liver, it's difficult to slice open because fatty and bloody. It's also difficult laparoscopic. I agree with the comments mentioned by both of my co-speakers. The pneumoperitoneum helps a lot to decrease that oozing from the cut edge. That's particularly true in a fatty liver. And we'll put the pneumoperitoneum not to 20, but to 15 or 16.
And that was going to be my next question. It helps you, but you're probably a little concerned about the embolism. Professor Wakabayashi, you mentioned about controlling and decreasing it, and then that's going to be reabsorbed. Dave, do you feel comfortable with that? Yeah, I'm going to see some CO2 going to the heart, but I'm just going to wait until reabsorb, and I'm going to take these temporary changes on the blood pressure.
You get microemboli, if you put a transesophageal echo in animals or humans, you get microemboli all the time at laparoscopy, but it's not clinically significant. The studies show you need a huge amount of air embolus to lead to a clinically significant or fatal air embolus. It's a theoretical risk that we were really worried about in the beginning, but in the 3,000 cases in a world review, there wasn't one single death from air embolus. No. And if it happened all the time, we would be seeing this. So I think the answer is it happens subclinically, and as long as you don't have an open cut vein, we never leave a hepatic vein stump open and gushing like we saw in the pig, and we hope we never see that. But I think that clinically it's not a problem. It's been proven it's not a problem. The only caveat would be don't use the laparoscopic argon. There's been deaths reported. That's the one instrument where it puts such a high pressure flow rate that and the argon, I think it probably goes more than the CO2. So that's the one device we've abandoned. We used it early on 10 years ago, but we don't use the argon because the argon gas is delivered so rapidly, the pressure limits go up from 20 to 40 within a few seconds.
Any comments, Dr. Professor?
Yes, I agree, Dr. David. Yes. And for this, it's different from pig and human. So I think that although gas embolism report is very rare, we try to be very careful. So if there is a hole, I think that we don't do any more steps. So I stop, then lower the pressure, and we try to control it very carefully. Yes, not elevate the pressure.
Any last comments, Professor Wakabayashi?
The reason why we started laparoscopy-assisted major hepatectomy is we had a fear for new CO2 embolism. But from the experiment and also from the literature, probably those CO2 embolism is a subclinical setting. And also air embolism. If you have an open liver section, you have a big hole in the vena cava, air goes into the circulation, that would be worse. So CO2 is better.
Thank you very much. With this, we're going to close the session. We're going to try to put this session in SAGES TV for anybody that wants to revisit it. And we'll make sure that all the videos play on SAGES TV. Thank you very much.